Hello guys, welcome to the first episode of Ahmedical Education. So, let's see this case. A 75 years old patient is brought to the emergency department due to confusion, agitation. The patient reports seeing snakes on the wall, so the patient is having visual hallucinations. Past medical history is insignificant except for chronic alcoholism. The vital parameters of the patient are the following. Temperature, 39 degrees Celsius. So the patient is having fever. Blood pressure, 160 to 77. So the patient is having hypertension. Pulse, 123. So the patient has tachycardia. Respiratory rate is 21. So the patient is tachypneic. So you have an elderly individual here with a past history of alcoholism who's coming to you with autonomic instability, with agitation, with altered mental status. Physical examination, so the patient is having fever. We have to look for signs. We have to look for a possible cause for fever. So lung, there is no evidence of pneumonia. Head and neck, there is no evidence of lymphadenopathy, which means the patient does not have some tooth abscess or some other problem. There's no neck stiffness or rigidity. This is extremely important in patients who comes to you with fever and altered mental status, because this is meningitis is a potential cause for fever and altered mental status. Heart, there's no evidence of murmur, so infective endocarditis is unlikely. Now, your patient has a history of alcohol consumption. Maybe your patient has cirrhosis, so we have to exclude spontaneous bacterial peritonitis as a cause of fever. So here, abdomen, it's soft, it's non-tender, and there is no evidence of organomegaly. There is no evidence of hyperspllenism or splenomegaly. Neurologic, now in any patient who comes to you with altered mental status, a thorough neurological examination is extremely important. So the pupils here are round, they are reactive to light, and they are symmetrical, and there are no focal neurological findings. This patient has fine tremor, which is okay in patients who have alcohol, in patients with chronic alcohol consumption. Definitely we have to look for asterixis, which is flapping tremor, in patients with end organ damage, in patients with liver cirrhosis in this case. So, your patient is confused, he has altered mental status, he has visual hallucinations, he's agitated, and he has autonomic instability. Now, the first thing that we have to do in this patient, since he is an older patient, is to differentiate and to decide whether this is an acute problem, which is delirium, or it is a chronic problem, which is dementia. Now, delirium is characterized by an acute waxing and waning course, which means that there is a fluctuation. There is certain times of the day it's better, certain times of the day it is worse, and usually delirium worsens at night, and this is called sundowning phenomenon. If you contrast this to dementia is usually chronic and it is usually slowly progressive. So we're talking about a course of years, months to years. Now, definitely there are different types of dementia. Vascular dementia, it's characterized by a step-like progression. So usually the progression is faster, but this is beyond the scope of this episode. Delirium is reversible. If you correct the underlying cause, then it will get better. This is not the case with dementia. This is a key point. Patients with delirium are inattentive. So you try to communicate with the patient, you try to tell him a joke. If the patient laughs at your joke, then most likely he's in delirium. You try to tell your patient a joke. If the patient does not catch your joke, if the patient does not pay attention to you, so most likely he is in delirium. Patients with dementia have a preserved attentiveness. They are attentive. Another possible test that you can do is definitely you can ask your patient to repeat certain numbers. For example, 4, 5, 7, 3, 1. If your patient is inattentive, if he is delirious, he will not be able to repeat the numbers. Patients with dementia will be able to do so. The consciousness is fluctuating in patients with delirium. This is not the case in patients with dementia. One important distinguishing point is hallucinations. If your patient is having hallucinations, he is having delirium. This is the case in our patient. He is having visual hallucinations. Now, visual hallucinations tend to be due to an organic cause. Auditory hallucinations tend to be due to a psychiatric cause. But again, so the point is, in deciding whether the patient is having delirium or dementia, we ask the family members if this is acute or if this is chronic. The second thing, we look if the patient is paying attention to us or not. And the third thing that we have to look for is definitely the presence or absence of hallucinations. Now, what are the causes of delirium? Or what are the causes of altered mental status? Now, there is a huge list of causes. So it can be summarized in move, stupid, metabolic. For example, hypernatremia, hyponatremia, hypercalcemia, hypocalcemia, hypoglycemia. So this is metabolic. Oxygen. So for example, if your patient is hypoxic, then he will tend to have delirium. So we just have to measure the oxygen saturation of the patient, and we have to do arterial blood gas. We look for evidence of hypoxia. Vascular. So this is very important. If your patient is having a stroke, this might be a cause of altered mental status. So this is why we have to examine the patient for the presence of focal neurological deficits. Altered mental status plus focal neurological deficits equals CT scan of the head. Endocrine. So if your patient is having myxedema coma, hypothyroidism, his mental status will be altered. So this is why in all patients with altered mental status, whether it is acute or chronic, we have to measure the thyroid stimulating hormone, TSH. Yeah, we will come to this. Seizures. So after seizures, there is a period of post-ictal state, and patients in post-ictal state have altered mental status. It's called Todd's paralysis or Todd's paresis. Trauma, well, basically hemorrhage, can cause altered mental status. This is why we have to examine the patient neurologically to look for focal neurological findings. Uremia, it's very important. Psychiatric causes is important. The most common cause of delirium is infection. So this is why, and the most common cause of infection that causes delirium is urinary tract infection. And this is why we have to withdraw blood from the patient. We do complete blood picture, C-reactive protein, and we have to do urine analysis, urine culture. If the patient has fever, we do blood culture. If the patient has fever plus altered mental status, it is a must to do a lumbar puncture. Again, it is a must to do a lumbar puncture in patients with altered mental status and fever. Drugs. Drugs cause altered mental status. So benzodiazepine withdrawal, benzodiazepine intoxication, opioids, they cause delirium. So what investigations are required in this patient? Like we said, the causes of altered mental status are electrolyte disturbances, metabolic causes, and infections. So we have to look for these. And definitely we have to do imaging studies to exclude intracerebral bleeding. So we do complete blood picture, C-reactive protein, electrolytes, including magnesium. Many patients with delirium tremens have magnesium deficiency because alcoholics usually do not pay attention to their diet. Fever, we do chest x-ray, urine analysis, culture, blood cultures. Confusion plus fever, which is the case here in this patient. He is confused and he has fever. We have to do a lumbar puncture. Before we do a lumbar puncture, it is a must to exclude an intracerebral space occupying lesion. Otherwise, we will endanger the life of our patient. So we have to do here CT of the head. Anytime the patient has altered mental status plus focal neurological findings, a CT scan of the head is necessary. Anytime we want to do a lumbar puncture of the patient, anytime we have to do a lumbar puncture on the patient, we have to exclude an intracerebral space occupying lesion. We either do fundoscopy or we do CT scan of the patient. It's up to you. Do you want to do a fundoscopy on a patient who's confused? Good luck. So, we talked about this differential diagnosis of altered mental status. It's either metabolic, like hyper or hypoglycemia, electrolytes, we talked about them. Thyroid function tests are extremely important. Now, the patient has alcohol problems. The patient drinks a lot of alcohol, so maybe he has cirrhosis, liver cirrhosis. So this is why we have to do liver function tests. We have to do coagulation studies because, well, these are called the synthetic liver function tests, which is albumin and prothrombin time. They're very important. Medications, so we have to look what medications the patient has been taking or is taking. Drugs, so drug abuse and alcohol. Pay attention that patients, hospitalized patients, may have delirium due to pain. At the same time, hospitalized patients may have delirium due to opioids. So it's like a scale. You have to decide whether you are giving too much opioid or you're giving too little opioid, that your patient is in pain and because of the pain he's delirious. Infections, we talked about them. Infections are a super important cause of delirium. The most common cause is a urinary tract infection. And last but not least, delirium tremens versus alcoholic hallucinosis. Now, what is the difference between delirium tremens and alcoholic hallucinosis? Now, essentially they're the same. Usually they occur 8 to 10 hours after the last time the patient drank alcohol. Yeah. Maximum we see this at 48 hours. The only difference between delirium tremens and alcohol hallucinosis is that patients with delirium tremens have hallucinations and hyperactive autonomic nervous system, while patients with alcoholic hallucinosis have hallucination with no changes in the autonomic nervous system. So autonomic nervous system instability, which is the case in this patient, is the difference between delirium tremens and alcohol hallucination. Patients with delirium tremens have autonomic nervous system instability. What is the treatment? For both of them, the treatment is the same. We give benzodiazepine. Now, definitely there are some other causes of altered mental status in patients with alcoholism. So sometimes a patient comes to you or is brought to you to the emergency department with altered mental status. Now, maybe he has drunk alcohol. This is one possible cause. Maybe he is in alcohol withdrawal, so delirium tremens, or alcoholic hallucinosis. Maybe your patient is having Wernicke encephalopathy. So Wernicke encephalopathy, well, it can be acute or chronic. It is characterized by confusion, ophthalmoplegia, and ataxia. This is to differentiate it from Korsakoff encephalopathy, which is always chronic. Korsakoff encephalopathy is characterized by amnesia and confabulations. So the patients forget and then they confabulate. One possible cause of altered mental status in patients with alcoholism is subdural hematoma or intracerebral bleeding. Keep in mind, patients with alcohol consumption problems, they usually have atrophic brain and usually they are unstable because they are always drunk, and when they fall, then they will cut the bridging veins in the subdural space because the brain is atrophic, it is small, and it moves in the cranium, and this would result in lacerations of the subdural bridging veins, and it would result in subdural hemorrhage. Infections, we know this. Now, how do you treat a patient with delirium tremens? Well, you give benzodiazepines. The best benzodiazepine to give is chlordiazepoxide. Why? Because its blood level is predictable. It does not fluctuate. Yeah. Now, not most patients, but many patients with delirium tremens have a concomitant cirrhosis, and in these patients you are not allowed to use all benzodiazepines. Patients with liver cirrhosis should not be given diazepam. So instead, you can give them lot, either lorazepam, oxazepam, or temazepam. This is important. If your patient with delirium tremens develops a seizure, you give him benzodiazepine. If this does not help him, you switch to barbiturate or propofol. You do not give phenytoin. Phenytoin in patients with delirium tremens, with seizures due to delirium tremens, do not work. Another commonly made mistake is that patients with delirium tremens are given haloperidol because they hallucinate. This is wrong, because haloperidol lowers the seizure threshold. So patients with delirium tremens who are given haloperidol are more likely to develop a seizure. Please do not give your patients with delirium tremens haloperidol. It is wrong. Now, these patients, you don't know. Your patient has altered mental status. You don't know whether this is due to delirium tremens or this is due to Wernicke encephalopathy. And this is why you have to give thiamine. You give thiamine before you give glucose. Now, another cause of altered mental status in patients with alcohol consumption problems is that maybe your patient is having hypoglycemia. Especially if your patient is tachycardic. If he comes to you with altered mental status and tachycardia and sweating, you don't know. Maybe he is having hypoglycemia because he has liver cirrhosis and he does not have glucose reserves. Now, patients with liver cirrhosis, they cannot produce glucose from gluconeogenesis because the liver is cirrhotic. They cannot produce glucose through glycolysis because the liver is cirrhotic, and at the same time they don't have money to buy food, so they cannot take glucose orally and they cannot produce glucose because the liver is cirrhotic, and sometimes they develop hypoglycemia and they come with tachycardia, with sweating, profuse sweating, and altered mental status. So don't forget it. So patients who come with altered mental status, alcoholicers with altered mental status, maybe they are hypoglycemic. Before you're allowed to give glucose, you have to give thiamine. Otherwise, you will make the situation worse. Now, sometimes you might consider giving magnesium sulfate in patients with delirium tremens, especially if they have seizure. Why? Because magnesium is a cell membrane stabilizer. So we give magnesium to patients with torsades de pointes, this arrhythmia. Yeah. How do we treat this torsades de pointes? Due to prolonged QT interval, we give magnesium sulfate because it's a cell membrane stabilizer. Yeah. The same way it stabilizes the cardiac muscle, it stabilizes the neurons. Pregnant women who come with seizure due to eclampsia are treated with magnesium sulfate. So it's the same principle here. Now, your patient might be having autonomic instability. So the patient comes to you with hypertension, with tachycardia, you give him diazepam and you wait. If he continues to have hypertension and tachycardia, you might consider giving clonidine, which is alpha-2 agonist. It acts centrally, or definitely give a beta blocker like atenolol. Now, well, this is not related to altered mental status, but it is a possible complication of alcoholism, it's called wet beriberi. So basically it is a dilated cardiomyopathy due to alcoholism, due to chronic alcoholism. It is a high output cardiac failure. The pathophysiology behind it is that patients with alcohol consumption do not have ATPs, and because they don't have ATPs, the vascular smooth muscles do not contract because it requires ATPs for the muscle to contract, and this is why these patients have generalized vasodilation, and vasodilation means cardiac output has to go up, so the heart has to work harder, and because of that, over time it will fail. What are other causes of dilated cardiomyopathy due to high output cardiac failure? So it's either arteriovenous fistula or Paget disease of the bone. So in Paget disease of the bone is metabolically active. All bones in the body are super metabolically active, and because they're super metabolically active, they require more blood because they require more oxygen. So the heart has to pump more blood to the bones, and this is why over time it will fail. So Paget disease of the bone, thyrotoxicosis, wet beriberi, arteriovenous fistula, and chronic anemia are the differential diagnoses or the possible causes of high output cardiac failure. Now, why did I say that thyroid is important? So in patients with dementia, you are not allowed to diagnose dementia or to talk about dementia before excluding secondary causes of dementia. What are the secondary causes of dementia? It is either hypothyroidism or it is vitamin B12 deficiency. And this is why in all patients with dementia you have to measure vitamin B12 level and you have to measure TSH level. Well, dementia due to a thyroid problem, due to hypothyroidism, is called pseudodementia, which means it's not really a dementia. So if you check the thyroid levels in patients who has dementia and it is the thyroid stimulating hormone is high, you give thyroid replacement and most likely the dementia will disappear. Thyroid problems or hypothyroidism is a reversible cause of dementia. This is one thing. Other thing, patients with B12 deficiency can develop a wide variety of neurological manifestations. Subacute combined degeneration of the spinal cord, peripheral neuropathy, or even dementia. So you are not allowed to forget pernicious anemia as a possible cause of dementia. Well, definitely there is the multi-infarct dementia, there is the Lewy body dementia, which is basically an inclusion body dementia, and there is also Alzheimer's dementia. But this is beyond the scope of this episode. We'll talk about it. Thank you so much, and I wish you all the best.